Go ahead, Jasmine. Can you hear her?
Well, no, because I have the volume turned off on my machine. Otherwise, we'll get feedback, right?
Yeah, you might.
She's not even in the chair yet on my machine.
Okay, so there's a
Oh, no, wait.
there's a solid 30-second delay on our end.
There she is. Okay.
All right, now I'm gonna switch. I'm gonna switch the picture so you see where you need to be.
Okay.
It's really close. It's really zoomed in. And unfortunately, that was the best. That's the best I could do with what I'm working with right now. So you're gonna have to either maybe have to stand up or scoot far back. You'll see in a minute.
It's really bright on the other side.
Yeah, I know, right?
Okay, well, I need to see this via YouTube. Hang on. Let me follow the link. Because I'm just seeing too many things here.
And then you can click.
Can he move his camera down? Can you hear me? Way down lower. This is what I'm seeing in YouTube.
Yeah.
So that's not gonna work.
So he just needs to come back a little bit.
Where are you getting this image from?
That's from the FaceTime camera. It will only let me get so much of that. So much of that screen, if that makes any sense.
This is why I wanted to use a camera rather than a computer camera.
That's good right there. Maybe a little bit more. Maybe like another 6 inches, maybe.
Maybe another 3 feet.
Oh, she's saying 3 feet.
Pretty long delay.
But you need to be able to see the questions. We should have brought him the backdrop.
Perfect. Yes, I like it. Is that good?
It's okay.
What do you mean it's okay? I mean, this is our first time doing this.
Next time he won't be homesick.
Next time he won't be homesick. All right, fair enough. All right, I think that works good. All right, so then hit transition.
Hit transition. Where's the button?
Shit, I already put it up.
Oh. But is this uncovered? Oh, that's this way. So we're not even gonna have Craig in the corner.
You're missing what? What are you missing?
I hear you, but like, why can't this camera be this?
I don't really want Craig sitting on my shoulder.
Because this is what happens.
Okay.
So this is the built-in FaceTime camera. So when he calls FaceTime, those two things link up.
Okay.
This is talking to YouTube and it's talking to OBS. I can't do it that way.
Okay.
Not on this short of notice.
No, I hear you.
I can't do it.
I hear you. All right.
This is the best I can do in a pinch. I think it'll work. I
We're
think it'll be fine.
As we have to teach classes mobily, we'll have better tools.
Well, yeah, of course, and if we're doing a mobile class,
Better tools coming soon.
it just, all we're gonna need is the one camera.
Not necessarily.
I've been watching that webinar, WebEx. I don't know. Yeah, it's called WebEx, isn't it? I was talking about it the other day. I'm thinking about using that for teaching classes mobily.
My point is, the students, we're not gonna be trying to FaceTime with the students.
Yeah, but you can see
My
them.
job right now.
What's that? What'd you say?
How's it right now?
I can't hear him.
You're still you're a little bit cut off.
Where?
The bottom of
Bottom.
your chin.
Bottom
What
of
do
your
you
chin.
mean? Put it back to my camera on YouTube. Would you?
Okay.
It's my undisclosed secure location. Is that what this is? Like Dick Cheney?
Yep. You're protected. Or
Least
already exposed. One or the other.
That's the settings on your computer.
All right, when you're ready, I'm gonna send the email out so people can log in and hang out for 30 minutes or whatever, so they can post it on their social media.
God, I got really bald.
It just
Like
ha-
badly. Disappointing.
It's a symptom of the illness.
It is. That looks okay, right?
I think that's much better.
Can you see my live shot right now?
I can
Or
see you, I
you-
can see you live and I can see you on YouTube.
Okay. All right. So Jasmine, you saw my thing that I sent, and then you had other things you suggested we talk about.
I just was kind of like putting it in a different order, so maybe when you're speaking about it, so that people can absorb it in the same way that they run a call. Here I am. We already have viewers, so I'm gonna undo that. All right, so this link is out, it's live.
Okay.
All right. Hey, can you put it back over to the empty chair? I did it, just kidding.
How's the volume now, Terry? Somebody type something. How's the volume now?
Do we need a mic?
Hello, hello. Check, 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 check. Watch that.
So 30-second delay.
Watch this right here. How's that? Is it peaking in the yellow or red?
No, it's green.
Green?
Green.
How about now?
You're still green.
Okay. Kind of just what's up?
Is my sound on right now?
Yes.
Chief Tokars, can you hear me okay? It'll take him a little while to answer.
30-second delay. Where's my Uber?
Is he on his boat?
That's it.
Very low volume.
I think he's on his boat.
Alright.
Can you see me?
Yes.
Can you hear me?
That's the question.
Yeah.
Yes, Dr. Jameson can hear you.
I don't know if anybody else is coming over, honestly, although we kept inviting them.
We have 23 people watching now.
Okay, so he has the stream. I'm going to use my phone to go and test the volume. I'm going to shut my computer down. You can see the questions on your end, right? If she sends you the link.
Okay.
If you see, she sends, actually, I'll reconnect this in a minute. I just got to figure out a little bit more.
If you want to send me a link, then I could put it on.
Let's send it out in email.
Oh, okay.
No volume.
Did you, I'm working on it. Did you,
Do you need me to go get the mic? Sure.
what would you?
Moving closer, is that what you're doing?
I'm thinking,
We could just move the table that we're sitting at.
no, because it's going to screw up my camera.
So you just want to move the computer closer. Is that what you're saying?
I think so. I just don't know if I got enough room. Can you email me that link, please?
Let me text it to you?
However you can get it to me, it's fine.
Sent. I miss my Uber again. I'm gonna cry.
All right, you want to give me a sound check?
Hi. Hello, hello, hello.
Check, 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 check. 1, 2, 3, 1, 2, 3. Can you guys hear us?
Can you make me shorter, taller?
Yeah, I can adjust it.
So Angus, can you hear me?
I can.
Oh, good. So how are you?
Doing okay.
Are you feeling crappy?
Only mildly.
Huh. there
that weren't-
particular things that you want me to cover versus you cover?
No, I was just gonna go through that outline I gave you today. We do not have the next MCD ready because the state just updated their guidance this afternoon, so we're gonna have to do a few edits. But I thought it was worthwhile to continue to get questions from people so we could figure out what other issues we need to address.
Okay. So is this opened up for like everybody at this point?
Yeah,
And
it's
we're
open.
actually live?
Yeah.
Oh.
You have to speak up though. For some reason, the sound isn't very.
Oh, okay. Well, we can speak up, and does that
You
mean
see
that you're ready to go?
Do you see the comments there that they can hear me okay, but not you guys?
Yeah, not good. Volume steady max on my end. Okay.
It's
I can
nice.
I can sing or something. La la la.
We're maxed on our end.
Hey, Chief. Hey, it's Craig. Yeah, we're just getting everything ready because it's a 4 o'clock. Yeah, we're working on that now. So we're on a 4 o'clock start, but we're live now. Once you turn it on, I guess you're on. So.
Hey,
Yeah.
Jasmine.
Okay, so I just waited now. Oh, I see. Okay. Okay, that's cool. Oh, thank you very much. Okay, bye.
Anyone? Go ahead. Good signal. Go ahead, sir.
Nothing on the notes here abstract notes or any kind of respiratory exploration. I'll be down here check multiple times before we exit the vehicle. Final level patient side, patient was presented with some extra chest pain. We went ahead and started our assessment and
I
treatment
think Andrew was coming.
during the assessment and interview. Patient did indicate that she was on a cruise 6 weeks prior, did develop a respiratory infection and started to report a week after she got back. So she's been going through treatment for a respiratory infection after the cruise for about the last 5 weeks. Patient is not presenting with any kind of active problem, fever, having the call was for cardiac, or not cardiac, for chest pain, and we just wanted to touch base with the possible complications associated with the cruise and then the respiratory problems.
Copy. Sounds pretty unlikely 5 weeks out. Where was the cruise to?
Is there a closer microphone or where am I?
You're on the mic.
Copy. Unlikely that there's
Oh,
COVID.
I'm trying to project to that. Okay.
Understood. We kind of focused in right go ahead and the vehicle. Go ahead.
Test 1 2 test. Even if I'm kind of yelling, I can't get above the lower end of the green. Check.
webinar is over in so a couple hours. Yes, sir. Thanks so much. You're welcome.
Hey, can you guys hear me any better now?
Yeah, you actually sound really good. Do I sound any better?
I don't know. I just put AirPods with a microphone in, so maybe that'll help.
Oh, okay.
Or, let's see. I'm gonna have headphones in, but maybe that'll help with echoes and stuff.
Hello. Who's online? Hey, Jim. Who's online? Are you picking up call?
Yeah, we got a call for docking to the server.
Good. Okay.
Jasmine, if I click on that link, will I be able to get this on this telephone file? And is each time you do this, each link different, or is it the same?
So Ed's sending me something with EPCR information in case we get any questions about that.
Okay, that's cool.
But that's gonna be back in just a minute.
I got the link ready, look good.
Thanks. Yeah, I look better than I sound, apparently. I wonder, can we just keep bringing that iMac closer? Is that
A little bit of a
strategy?
shadow in the background.
He's got a mic coming, but he's grabbing it.
Or I wonder, can I do what Angus did?
What? The big
As
sound?
far as,
Well, this is
going
picking
to-
you up on the mic.
Gotcha.
But you should be able to, can you read the comments on your computer?
I can, yes. I logged in and I can do that.
I'm gonna send this to you. Email or text, how do you want this? The information on EPCR. So via email.
Oh, cool. Okay.
Yes. Or, no, you saw what the problem is. We actually went through a good test.
Should it be flashing when I'm on?
Hold on one second.
tough questions or ask?
Both, probably. Okay, is that better out there? Does it look better?
Test, 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 test. That should be good. Yeah. All right.
Okay.
How about sound check now?
Sound check now. Test 1, 2, 3. No sound at all.
30-second delay.
Yeah.
It's a 30-second delay. Okay, so that that'll help.
But we can see that the sound looks much louder over here.
Oh, good. Okay.
There it is. Way better.
Much better on the volume. Hey, good. Note for the record, I am not an actor. Note for the record, there's a lot of fire chiefs texting me comments about how I appear, good or bad.
I'm gonna be off camera right here if you need me. Do you want me on camera?
Here, well, otherwise it'll just look weird.
Unprepared.
Yeah, we're all prepared.
So this is EPCR stuff.
Oh, good. Yeah, I got it. Okay. And then I can't see if Doc is on or whatever, so...
You'll see when it switches, because we'll switch between.
Oh, we'll switch between the two. Okay. Okay, we're 4:02. Does Angus want to start? Or?
Let's start with him.
Dr. Jameson, do you want to start?
Sure. Can you hear me? Okay, you ready?
Yeah, go ahead. Yes, go ahead.
Okay, it looks like we have about 100 and something people on the line right now, and so for the folks that are joining us this afternoon, just please be aware that there's about a 30-second delay. So when you put a comment in, we may not answer you quite right away, but we are able to see your comments, and we'll try and answer them as best as we can. So, thank you guys all for tuning in this afternoon. I think it was important to get us together in a social distancing kind of a way to make sure that we can answer any questions that you all have. I do have a couple of things I want to go through just about our general situation right now. And then following that, I'll turn it over to Craig for his comments. And then I think we'd like to just hear questions from you all. You can put them right in the chat room, and we will try and answer them as best as we can. I was hoping that we would have a medical control directive ready to go for this, and we could walk through the new steps. However, the state has just updated their guidance within the last hour or two, and so we need to go back through that and make sure that there's no other changes we need to make before we release the medical control directive. So first, I want to talk about sort of a situational update, where we're at, what's going on with this. And here's the deal. The deal is there are thousands of cases in the United States and well over 100 cases in the state of Florida. They announced 2 more cases in Pinellas County this afternoon, bringing our total confirmed cases in the county to 4. There are 5 cases in Hillsborough, I believe 5 in Manatee, and 2 in Pasco, so our area here does have cases. It's unclear right now whether these are all travel-associated cases or whether there is the beginnings of community transmission, but I think it would be prudent to assume that we're seeing the beginnings of community transmission. And so with that, I think it's a good time to start looking at changing our posture on this and making sure that we're all on the same page. So the reality of this situation, I'll try and turn it up. So the reality of this situation is that is that, we are on the front line of this. We are at that unique crossroads that we talk about with EMS between public safety, public health, and healthcare, and all of those disciplines are exactly the frontline disciplines in this particular event. And this is going to be an event that's a little bit not like a normal event, because we're used to hurricanes, and hurricanes kind of happen and then we get into mitigation pretty quick. But that's not necessarily what we're going to see here. So this has the potential to last for weeks to months, and this is going to be something that's going to put a strain on all of us over that time. I know one thing that we're all worried about is healthcare provider and EMS clinician infection rates. And there are various numbers being tossed around. Some people will say it's in the 5% range. So that's 5% infected, but then obviously a smaller number than that with severe illness. So that's number one, is we are clearly on the front lines of this, and we can expect that it's going to impact us. And number two is that even despite that particular job role, all of us in the community have a responsibility. There is no vaccine right now for this. There are no proven antivirals or other medical therapies. And therefore, really old-fashioned community action is what it's going to take to flatten this curve down. The goal at this point is to keep this from being a big explosion and rather keep it being a slow burn. And that really means that we all have to do everything we can on social distancing. I am currently at my house because I have an upper respiratory infection. So rather than be in the office and spread that to other people, I'm at home. And that is what we should be doing right now. It doesn't mean you have to stop working. Obviously, you can't be on a truck from home. But if there's any way that you can not put yourself in contact with other people, this is one of those tough times. If you have family, parents, or other folks in town, you may consider as a healthcare worker and as a frontline responder on this that you might not want to spend any time with them over the next few weeks in order to keep their risk as low as possible. So please pay attention to the social distancing and the old-fashioned public health, community health type activities that you can take. And please help us in advocating those to the broader community so that everybody does as much as we can. If there's one person I would suggest that it might be worth your time to listen to when you see them on the TV, it's Dr. Fauci from NIH. This is the guy who knows what he's talking about. He said a few things recently. One, he said that it's going to get worse before it gets better. And two, he said, I hope that I will be accused of overreacting to this, because if I'm accused of overreacting, then I will have been successful in flattening the curve. And so I think those are two very important pieces to keep in mind as we go through this. So the next is who is at particular risk for this disease. For the vast majority of people, this is a mild to moderate illness. The folks who are actually at significant risk are generally the high-risk groups that you would expect. So older folks, people with underlying past medical history, and immunocompromised people. Children tend to actually get very little, if any, symptoms with this, though they certainly can be infected and pass the disease between folks. So that's something to know about. The other thing to know about is that there is evidence of asymptomatic transmission. So unfortunately, that makes this whole thing a lot more difficult for us. And it goes back to why social distancing in general right now, regardless of how you're feeling, is probably the best thing that we can do for our community, for our patients, and for our families. So given that we're on the front lines, given that there's still a lot that we don't know about this particular disease, what can we do? Well, one thing that we can do is have the medical community do what they're already doing, which is as quickly as possible find out more about this virus, how it infects the cells, who it tends to cause severe disease in, and how the best way we can treat it. So all of those things are underway, but it's going to take some time. Additionally, a vaccine would be great, but the chances of us having a vaccine ready for human use in the next few months is very, very low. Most people are saying a year or more to get an effective vaccine. So perhaps the vaccine will help us with next year's outbreak of coronavirus, but probably not this year. It is interesting to note that the underlying past medical history group for those at increased risk has some unusual things in it. So particular things to focus on would be mitigating your own risk factors. So if you have some health issues that you've been slacking on or you haven't taken care of, now would be a really good time to make sure that you're in the best shape you can in order to keep yourself safe. So once again, the primary thing for us as we go through this is going to be keeping you all safe, and that means primarily using appropriate PPE and making sure that we're using it at the appropriate time. And then following that, making sure that we each keep each other safe and making sure that we do our best to keep our workforce from getting sick so that there aren't too few people left to run calls. After that, the idea is to make sure that our hospitals don't get overrun. Those are really our response. So I'd like to address just a couple of other issues. One is what type of mask is recommended. So, it sounds like we're having some echo. If you guys want to mute the mic that's over there at CPM, that might help.
Oh, okay. I think it sounds like you're in your bathroom too.
I am most definitely not in my bathroom. But I think your mic is picking me up and echoing it. All right, hopefully with you guys muted, that'll help. In the comments, it'll take a couple seconds to catch up, but please let me know if you guys can hear it better now. What I would say is there's been some discussion about surgical versus N95 masks. Although that guidance may change, where in some cases they say it may be okay to use a surgical mask in the future, that is not currently where we're at. Currently, we are at a location or at a place where, although we have some shortages of N95 masks, that is still the standard, particularly for us in EMS. So I want to make sure that everybody is clear that the appropriate respiratory protection for coronavirus at this time, based on what we know, is an N95 mask. Surgical masks do not actually take care of this. As far as we know right now, that guidance may change, but this is the current guidance that we have. The rest of the PPE ensemble essentially is a gown, gloves, eye protection, a cap, and foot protection. The eye protection is really, really, really important. Apparently, whether through people touching their face or whether through people actually getting virus into the eye mucous membranes, there is some concern about risk for transmission through mucous membranes of the eye. So either goggles, which are on the way, or the full face shields are really important. Standard safety glasses don't necessarily cut it. I was hoping to give you all the updated guidance on exactly what the case definitions are and when to suspect it today. But unfortunately, as I mentioned, the state just updated those, so I'm going to have to go back through and make sure we're consistent before we put that out. But in general, what I would ask you to do is the same thing you do on any scene, and that is do your size up, do your assessment. I don't care whether you call it a dashboard assessment, a doorway assessment, standoff assessment, whatever it is. Dispatch will put caution notes in there if they have some indications, but those are based on what the call taker or the person calling on one told us, and they are only as accurate as what that person told us. So you need to make sure that you take precautions and think about whether or not you need PPE as you're approaching the patient before you actually get right next to the patient. And so one of the things that we'll be putting out in the next round of medical control directives in the next day or so is the concept of making sure that you have that initial sort of standoff assessment or doorway assessment, or whatever you want to call it, so that we can keep you safe and get you into PPE when you need it. Once you've done that assessment and you've determined that you believe the patient requires PPE based on their risk factors and presentation, you really need to do the entire PPE ensemble. There's no mixing and matching, and there's no doing a mask but not the rest or anything like that. So please pay attention to the clinical guidance that was out, which we'll be sending back out again, making sure that we're minimizing the number of folks at the patient's side and making sure that we're minimizing the equipment to the patient's side as we get that initial assessment and figure out exactly what we're going to do with this person. Limiting the number of personnel is important not only for exposure but also for our PPE supplies. Folks at Central Supply have done amazing work on PPE, but it is a finite quantity. We are hoping to get more from the federal government. We don't have that yet, so we have to be smart about when we deploy our PPE so that we have it for the ones we really need it on. And again, that goes back to stopping before you actually get within 6 feet of the patient and trying to figure out whether or not you need the PPE. So we'll be putting out in the next day or so, as I mentioned, some better guidance as to exactly how to do that, which will go along with the updated state recommendations today. Aerosolization generating procedures, so that's intubation, CPAP, high flow oxygen, suctioning, anything that makes the patient cough, sputter, or gag. Those are particularly high risk for healthcare providers, should be done only when absolutely necessary, should be done with full PPE and as few people as possible in the treatment area. That's already been out, but another piece we're going to add is that as you enter the emergency room, we're going to ask that you discontinue those treatments if possible while you go from the entryway into the negative pressure or isolation room. That's a request from the hospitals, and I think it's very reasonable to turn off that neb or give a quick break in that CPAP as we come through so we don't put a whole bunch of virus particles in the air for those few seconds that we're walking into the room. Giving those hospitals as much lead time as possible so that they can steer you into the appropriate area is certainly a best practice, and we are actively talking with the hospitals about improving the way that they can offload these patients for us to make the flow as easy as possible and as smooth as possible for you. We will also be updating when the requirement to call online medical control with these patients exists. Initially, as we were in this "it's coming" mode, we wanted you to call for everybody. Now that it's getting here, we're going to back that off where we really are only going to need you to call if you have a specific question. There's going to be a lot of these folks, and there's not necessarily the need to do a consult for all of them unless there's a specific question. And we will actually go ahead and give you some more direction on that tomorrow to get us into a more sustainable kind of a picture for this. Currently, a known case, that's a laboratory confirmed known case, should require a consult and ideally discussion with either myself or one of the other medical directors and Craig Hare from county to make sure that we slow it down and get everything done as safely as possible. The other question that I know people had is what to do if we think we might have been exposed. And so last Thursday evening, when we heard about the potential exposure at EMS Today, I pulled together the best resources we have on that, which is guidance from the CDC. There is guidance about what to do for a healthcare worker who is exposed in the community, as in not in the course of their work, as well as guidance for what to do for a healthcare worker who is exposed in the course of their duties. Both of those links, as well as the description of how to walk through that, will be published in the upcoming medical control directive as well. It did go out to all the chiefs and agencies last week after we had that potential exposure, but that will be coming out again as well. And so I think at that point, I will give it to Craig for a second to see if he has any other opening comments, and then we'll hopefully get into the questions.
Great. Good afternoon, everybody. You know, if you see me and I'm not behind the desk working on a budget, that it's got to be serious. So here I am, Craig Hare, Director of EMS and Fire Administration. We're working every day with Sunstar Management, with the fire chiefs, with the EMS chiefs. Doc and I are on the phone, practically by the minute with Department of Health. I've talked to the medical examiner more times in the last few days than the last couple of years. So we do want to feel that we're overreacting because we really want to keep you all safe. And that is the key, Dr. Jameson's opening comments, and certainly ours, is to try to keep ourselves normal operations and safe for just as long as we can. And that's really the key. Just to reiterate, 911, they're doing an incredible job. They're taking these calls, they're screening, but people lie. People don't give the full information. Sometimes there's barriers in communication, or if you have a real fast response time, we're not getting to that question just yet. So really walking in, you've got to slow that down and make sure. I was talking to a chief earlier on a vehicle crash. You're going to be walking up and may have no information. So we want to make sure that that you want to get taken care of and make sure that you're being safe. We know that the personal protective equipment is a pain, but really it needs to be all or nothing. We've talked with hospitals about kind of poo-pooing us coming in full PPE, and I've pointed out the guidance to them that the CDC says you should be in everything. So there shouldn't be any of that. We're working with them, like Doc said, on the corridors of getting us in and out of the hospital more quickly without kind of spreading around. And so I just want to make sure that you know that. Oh, I forgot that Jasmine's on the screen with me.
Hi.
So Jasmine Solomon is our EMS trading coordinator, and she's our truth teller of what really happens in the field.
Oh, great. So a few things. We're doing our best to keep you updated on Target Solutions. With things changing so rapidly, please make sure you're checking your Target Solutions as much as possible so you can keep up to date on things as they change. If you haven't noticed, we have added an intervention to the EPCR. The isolation precautions taken intervention is required on these calls. So just be aware, if you can't close out your call, you need to make sure that this is prior to arrival in your time. So at patient side will be start time, so you're gonna have to bounce it back from that to finish your report. And just to let you know, we are working on keeping you guys up to date training wise, so just keep checking your Target.
Okay, I was multitasking. You talk about PPE used in EPCR as well?
No.
Okay, I can cover what I know of that one. So there's a close call rule. We want you under where you sign the record or put in your name in the review section of documenting what PPE that you used. That's helping give us some real time on personal protective equipment use. So really keep in mind that if you're in full PPE, you're low risk and you're going to go home to your family. You're going to be social isolation if any piece of that is missing. So we had a crew working a code, and they took off their face shield, and they ended up being socially isolated for a few days in order to get the COVID-19 clear back from the DOH and the medical examiner. So we really, just want to emphasize that as much as we can. The patient care report we talked about. So we are working to maintain our supplies, both locally. We're buying things as quickly as we can. We've reported to the state, and that goes to the feds for the strategic national stockpile. We're using that as well. When you're going into the hospitals, please make sure that we're using good manners. We don't want to be leaning on the nurse's station or going to the cafeteria or kind of wandering around once we're in PPE. So once you've done transfer of care, go out, decon your truck, and then let's go from there. I want to get some of the questions, Doc, between you and me. So maybe at this point we can do, if you can see the questions. Recent travel to hotspots is kind of irrelevant now due to the fact it's in the States. So you want to talk about community spread?
Yeah, just when you toss it over, remember to hit the mute button on your mic there. As I mentioned earlier, the initial idea of tracking people's risk factors and where they were from hotspot That really was when we were trying to contain this and keep it out of our community. But now that we actually have cases in our community, containment is still a goal to try and slow it down. But isolation then becomes more of the goal. And so once you begin to see what may be indications of community transmission, the recent travel does become less relevant. It hasn't totally disappeared yet, although it may before too long. I'll have to check and see what the state's done this afternoon as to whether we actually pull it out this week or whether that remains in because it's still a little bit helpful in determining higher versus lower risk. So Dusty, that's getting to be the point where it's probably going to be irrelevant before too long. I see a question from Kyle, which maybe I'll jump into as well, which is, do we need 2 medics to ride in on a COVID patient? If the patient's yellow or green, can just the transport agency ride solo? So this idea of having the 2 medics ride in has to do with 2 things. One, donning and doffing PPE takes time and is potentially area for risk. So the more times you're in and out of your PPE, the more opportunities you have to slip up when you're doffing and inadvertently expose yourself. So that's one reason. The second reason is it preserves our PPE supply. If 2 people gown up and mask up and put on their face masks and everything and ride into the hospital, you're still going to need 2 people to unload. So after discussion with all the chiefs when we first got into this and with the Sunstar folks, the idea is if we're going to bring that second person to the patient's side, meaning we're going to transport them, then that second person stays with the patient in full PPE all the way to the hospital, assists with loading and unloading the stretcher, and then you guys can be buddies on getting out of your PPE and making sure that everybody's following appropriate procedures. So that's the reason for the 2 medics. It's more about the operational necessity than the clinical necessity at this point. So hopefully that answers your question, Kyle, and a few other folks I think have the same question.
Hey Doc, we had back when we were having some microphone issues, a question about clinician testing. So you want to walk us through our clinician testing?
Yeah, I'd love to. So this is a big issue for us, right? So this is right up there with keeping us safe and confident in doing our jobs. And getting tested right now is potentially frustrating and takes a while, and that's not where we want to be. I can tell you that there's a lot of work going on right now to make sure that that we get as quickly as possible clinicians and or patients tested so that we can minimize the amount of time you need to be off or be waiting for a result until you can get back to work. I have been and will continue to strongly advocate to DOH and other folks that there needs to be ideally a separate expedited lane for first responders to keep us moving through that process just as easily and quickly as possible. I'm optimistic, but I don't have a guarantee that that will happen. The primary thing here is that if you wear your full proper PPE, you do not need to be tested, and it's not an exposure where you need to stay off work and not see any more patients or anything like that. So again, the having that initial kind of a standoff and figuring out based on the dispatch information and your initial look and discussion with the patient before you get within 6 feet of them is really critical to preventing those exposures that you would need to get tested for. But we are working actively to make testing for exposed or potentially exposed first responders as quick and easy as possible.
So Doc, does that mean that on these cases we're going to take and if we are exposed inadvertently, we've got a couple of lanes in which to get people tested, whether it's Department of Health or the family doctor or a hospital?
Yeah, currently, really, the primary lane is through the Department of Health. I hope that by the end of this week, there will be additional lanes available. There is beginning to be talk about doing drive-through testing in the county, and that would be, big operations located centrally where people could drive through if they had an indication to get tested. And again, I'm trying to advocate very strongly that there's a express lane for us, essentially.
Great. I'll hop in. There's a question about when do we upgrade to Tyvek suits? And really, unless I'm wrong, Doc, it's going to be at the point that we're out of gowns, right? So it's about supply sustainment?
Yeah, that's correct. The Tyvek suits are a backup, just like the full face piece respirator, a PAPR, or an SCBA are a backup. Currently, we are following all guidance that we have about using the gowns, the face shields, and the N95s. And those other pieces of equipment, whether you call them Tyvek suits or level C suits or whatever people might have referred to them, that we got a few years ago and that we've continued to sustain, those are really our fallback position at this point. So please use the regular medical rather than chemical appearing equipment right now, for at least for as long as we can. To know the location of current COVID-19 patients can we? So the governor's executive order last week directed state departments of health to begin sharing the location of folks they have under monitoring or facilities they have under monitoring with us so that we could be as safe as possible. That has begun. And you will see already a speed note out there that looks a little bit differently. It reads something like, let me actually pull it up here for you and tell you, give me 1 second. It reads, Department of Health is monitoring this address. Please use appropriate precautions. Those are now being put into CAD, and so you may start seeing those, and that's one of the things that's in the packet of updated information for tomorrow. So the answer is yes, we will be doing that for you.
Yeah, and Doc, they'll get that as a page and as a caution note that pops up on the MDT or is in the line of notes. So anything that we know, you'll know when you're going on the call.
Yep. I see another question here about can we get county unit in service to just run these calls, units that are stocked with PPE? That is on the table. That is not something that we are necessarily at yet, but that is something that all the chiefs and Sunstar and the entire group discussed. We may get there at some point, but we're going to try and keep maintaining regular operations just as long as we can. I see another really quick one here. What about the new goggles with prescription glasses? And I would say use the face shield. That's what the face shields are for.
We had a texted in question, Doc, about shouldn't you have long pants on if you're wearing a gown? And I think that answer is probably yes, right?
That's a great question. Yes, I would encourage you to wear long pants.
As you're reading some posts there, Doc, I've got some just general announcements to give as well.
Okay, go ahead.
Okay, so we're going to start absentee tracking. Will probably happen starting next shift, that your agencies will be reporting back how many personnel on duty and how many have called out sick. We're also rolling out temperature checks, not to be too invasive personally, but just making sure that everyone is well as they come to shift. And that'll have probably a couple of questions followed by a temp check, and probably happen right as you're coming into the station. We're asking for all students to be off the truck, so that'll communicate to St. Pete College, Manatee Tech, and School of EMS here shortly. And so your agency may have already started that, but that'll be countywide here soon. And let's see. Okay, you ready for the next one? Oh, I guess I'll talk about working groups. We have a hospital working group with the hospital administrators. Some of you expressed some concerns about how forward-leaning they are, and so we had a great call with them today. We also have an EMS and fire working group with the chiefs and EMS chiefs and Sunstar medical director and us. And so we are looking at the plans as this continues to escalate, whether it be a flu line or a medic-based refusal or alternate destinations. And so that's going on in a planning phase right now as well. Go ahead, Doc.
Okay, so a couple other ones. So one person said, what about the long pants? They need to be switched out after the call since your legs aren't fully covered by the gowns. We do not have that in any recommendations from the state or feds at this point. And certainly in the hospital, they're not necessarily changing scrubs in between patients, but we will double check that we don't see that. Additionally, I see a question about surgical masks for us so that we don't infect our patients. And what I would say to that is two things. One, that the surgical mask you are correct about preventing droplets from you heading towards somebody else. What I would ask, though, that is if you are sick and you think you need to have that protection for your patients, you probably shouldn't be at work right now because you don't know whether that sickness you have is truly a cold or you're just a pretty healthy person and you got a very mild case of corona. So to the point of responsibility to our patients and our coworkers and our families, if you are sick right now, you should be practicing self-isolation, and that is exactly why I'm sitting in my house and not sitting next to Craig. Next one is can you essentially downgrade somebody if there's a note on the call and then you get there and you figure out that there's absolutely no respiratory symptoms or risk factors? Can the crew revert to normal procedures? The answer is yes. You are making an assessment of what's going on with your patient. Dispatch, again, is based upon what is being told to them by somebody. I would probably encourage you that if you see the one about the DOH is monitoring this location, that you probably want to take that pretty seriously because that's directly from DOH. But the respiratory isolation, which this is actually a really good side note, respiratory isolation precautions at this point in your mind should say, cannot rule out COVID. Okay, so COVID, a high risk note or the DOH note should make your mind say, hey, there's a reasonable chance that this could be a COVID patient. But respiratory isolation precautions, as we get into more and more cases in the community, should in your mind read cannot rule out COVID. So you should take appropriate precautions. Now, if you get there and you're there for a broken arm and there's nothing else going on, yeah, of course, you do not need to burn our precious supply of PPE at this point based upon that. So this is one of those ones where you really need to make a good assessment and you need to determine what the appropriate and safe and reasonable course of action is for you. The last one I said was, or I see is something about, and I'm not sure I'm getting this correct. Oh, here it is. Are we being notified by hospitals if we bring a patient in who later tests positive for COVID? So more likely, you may get notified by the Department of Health at this time. But in the future, yeah, probably the designated officer from the hospital will contact the designated officer from your agency. But that is something that currently is probably going to happen through the Department of Health. And next one I see is, isn't known contact with a COVID patient a bit of a moot point now with the increasing asymptomatic COVID patients? So I don't know that we have an increase in asymptomatic COVID patients. I think we have some data that in a certain subset of patients, asymptomatic transmission, which means virus shedding, right? The virus is coming out of them in their secretions or they're airborne. In some certain set of patients, that they could be shedding virus before they have symptoms. But that doesn't mean that those other risk stratification tools shouldn't go into your assessment. At this point, we cannot run every single call in full PPE. So we really have to make sure that we're being reasonable about when. And I'm getting a text message question about can you downgrade? And so maybe it's worth reiterating. If you get to the patient's side and there is nothing infectious or respiratory or anything else going on, then yes, you can downgrade. But if you get to the patient's side and they have a URI, they have a cough, they have a runny nose, sore throat, fever, bellyache or nausea, vomiting, headache, any of these things, I would continue the PPE. There are some atypical presentations, and it's important to keep yourself safe.
Hey Doc, isn't it kind of the case that even during seasonal flu we should be in PPE? We just are very lax about it. So shouldn't this be how we look all the time?
It actually is exactly how we should look all the time. And one of the things that this has pointed out is that we as a group, all healthcare providers, have become very, very lax about appropriate PPE. And this is one of the things that this is exposing to us is that, boy, when you're working a shift in the hospital and it's flu season and you've got somebody who comes in with flu, you should be in essentially the same ensemble in terms of your PPE. And then we don't do it the way we should probably, and then maybe it's no surprise that there's 20 or 30,000 people that die from influenza in this country every year.
There's a question about statistically how many Pinellas residents will have the virus and be moderately ill or critically ill. Have any intel on that?
Sure. So I'm just trying to see. Can you read the question exactly? Because I don't see it right now.
Yeah, so I tried to go back. We got a lot more questions than I thought we would. So statistically, how many Pinellas residents will have the virus, then how many will be moderately ill and critically ill?
Okay, so how many people will get it? So that entirely depends on how well we do social distancing and appropriate isolation over the next couple of weeks. We have 4 laboratory confirmed cases right now. The number is clearly higher than that. But what we do regarding social distancing and slowing this down and keeping people safe over the next few weeks is what will determine how many we get. If we do nothing, people have estimated in the range of 60 to 80% of people would get the infection. If we are very aggressive, maybe we can keep it closer to 20% range. I'm happy to see that there's been more and more guidance about doing true social distancing, shutting things down, eliminating mass gatherings, staying home if you're sick, all the normal things that we would do for that. And so I think the actual number of people who are going to get the virus, get infected by the virus, is entirely dependent on how well we do that and how well we convince our community to do that over the next couple of weeks. As far as how many people are going to get serious, moderate seems to be somewhere in the maybe 30% range. Moderate means you probably have a pretty bad cough, maybe you have a little bit of hypoxia, maybe you're in the low 90s. And then there's a hospitalization, and that's rates probably lower than that, maybe 10 or 15%. And then of the ones who get hospitalized, at least based on what we've seen in other communities, about 30% of them go on to severe disease, with a high proportion of those requiring intubation for bilateral pneumonia and acute respiratory distress syndrome. It is an interstitial pneumonia, and it's actually been very amenable to treatment. So these folks are actually, unfortunately, spending a long time of needing ventilatory support. One of the reasons why the hospitals are so overwhelmed in some of the places where they've had a big explosion rather than a slow burn.
Okay. Hey, let me hop in. There's one that kind of ties to that social isolation, and it comes from the 911 center about if we end up in circumstances with multiple employees exposed or confirmed and cannot afford to quarantine the number of sick. So we're doing a number of things in the 911 center to try to address that. One is really upping how we're cleaning the radio consoles and the console furniture. We're working, radio and technology is working on laptops and portable radios so that we could further isolate folks that are not yet sick but could come to work but are socially isolated, and trying to spread that out. I know that there's a number of different things that Judith and the supervisory team is working on for the 911 center. Kind of in parallel to that, we're working on all the different types of social isolation in terms of changing meetings to conference calls. CME has been canceled. We're working on like closing our doors, so when EMS chiefs are bringing in equipment, we're closing that off. So we know that the 911 center is a key critical area for us to keep running. Doc?
Yeah, so there's a couple more here. I see some questions about triage out and leave at home, and that is something that we're working up right now. I don't believe we're there yet, but that is something that we're actively preparing a protocol for in what situation you could assess somebody, determine that they likely have COVID, and then advise them to stay home and contact the health department. So that is something that we are actively working up, as well as changes in how we would handle incoming calls, shunting folks to an information line as opposed to sending a 911 resource to them. There is discussion right now about alternate sites, and that is being worked up in the community. Currently, there's not set up alternate sites, but those are actively being worked up for where else could we take folks, and so that you'll have to stand by on that. I've seen a couple questions about reinfection or immunity after you've been infected, and the answer to that is we don't entirely know yet. There are reports of people donating antibodies and plasma in China after recovery, but there are also reports of reinfection. So I wish it was simple and easy, like once you get it, you have your mild disease, you're good. But not sure that's proven yet, so I wouldn't take that to the bank. It would be nice if a bunch of young, healthy people that work with us got it, recovered, and could go out and do this work without a whole lot of anxiety, but the fact of the matter is we don't know that yet.
Okay. Hey, Doc, let's go back to temperatures. And can you give us the cutoffs and the measurements and the guidance on temperature?
Sure. So we've seen two different things listed. The standard definition for a temperature is 100.4 Fahrenheit, which equates to 38 Celsius. And so that is the definition of a fever. There had been some guidance at one point that came out from the CDC that a temperature of 100.0 was adequate. I have not seen that repeated. So in general, the definition of a fever is 100.4. The caveat on that is that they don't have to have a demonstrated fever to meet criteria, and not everybody. It's only 80% of the patients actually get fever as one of their presenting symptoms. Some people get some more mild symptoms. So there's a question here about, are we going to be able to start checking temps to rule out COVID? And as much as I wish that was something that we could do, because it would be great, the answer is no. That's not going to be an effective rule out mechanism for us at this point.
Hey, Doc, let's talk about deconning your uniform, either after the call or after the shift. Kind of take us through both of those.
Yeah, that's a great question, and I am not aware of any hard and fast guidance on that right now. Have you seen anything specific?
I saw just a little bit in terms of, washing your uniform at the station, not taking it home, yellow bagging it, that sort of thing. You may want to switch your uniform if you've had exposure as well. Some of that's going to be limited by practicality of how many calls we're running, but certainly something to keep mindful of.
Yeah. I see a question here. Are we getting thermometers? Well, there are going to be thermometers probably to do checks on ourselves to make sure that we're not going to be bringing it into either the stations or our patients. But we simply can't get enough thermometers right now to deploy them for patients. And somebody said, can't we just use our ticks? And that actually was discussed as a potential solution. But no, given what I just outlined about the fever or lack thereof in the initial phase, we don't believe that that's a valid approach to ruling people in or out.
Yeah, I think nothing is foolproof here. There's a comment made that 46% of patients aren't initially febrile, and so or 89% was a correction. So there's no perfect information here. We're just trying to cut down the curve as everybody's been talking about.
I know the tick was a joke, but we actually did discuss it, so everything's on the table.
What are we communicating to our law enforcement partners? We do share the DOH list with them, and that goes to their communications center personnel, and so they do have that intel. We're asking them to stay 6 feet off from patients, from citizens, unless they need to go hands-on. And we are waiting for the working group to talk about personal protective equipment. We didn't do that initially because they're not fit tested for N95, and so we encourage them, if you're getting into a situation with a patient, you really want EMS and fire to respond.
Great. I'm just looking to see if there's any, here we go. What about going on system status management to help with ED overflow? Yes, we've already started talking to the hospitals about that possibility. We have a hospital working group that Dr. Cho and I and emergency management are working on a regular basis with our hospitals to support them getting prepared, but also to work on patient flow once we get into the thick of this. So yeah, absolutely. Once this ramps up, there's a very good chance we'll be doing system status management.
Jasmine's been sitting here the whole time, and she's got the inquiring mind questions that paramedics would want to ask. Got anything good?
Yes, I'm seeing them come in as you are. I had a comment from David Hudak that came in about the goggles. If you are not fitting the goggles because your prescription glasses, then you need to let your department know. Obviously, for the time being, use the face shield. And about CME, everybody's favorite thing to do. March CME was canceled. Obviously, everybody knows about that by this point, but the classes for the rest of the month, EPC, PHTLS, everything is stopped all the way until the end of March, and we'll update you as we get closer to April if we're canceling anything else.
All right, so if you've put up a question and we haven't answered it yet, put it back up because I think we've got most of them. But throw it back up there in the comments. We'll give you a second to get that done. Verify the decon process equipment transport unit, then remove the PPE. I believe, and you guys can correct me if I'm wrong, but I believe that Sunstar put out guidance on exactly how to go through that process. Is that correct, Jasmine?
Oh, here we are. I forgot whether it was solid or blinking when I'm on. So, Yeah, I can kind of walk us through it, and then people can correct me. David will text in or something. So we're using the hydrogen peroxide spray, and it has to have a 1 minute wet time before you wipe it down. It should be obviously everything that was touched by the patient, so the cot and any of your medical gear. But it also needs to be, since it can be droplet, it has to be the walls of the truck. It has to be the bench seat, and it really needs to be every surface across the unit. And that you should have on hand with you, and we're keeping up those supplies, so you should have that pretty readily available.
And you should be using that yellow blanket as much as you can when you know that you have one of these patients.
Yeah, so that viral shedding, if you think about Pigpen from Peanuts and Snoopy, you should be thinking that that's what the viral shedding looks like, and so you want to have them completely wrapped up in a yellow blanket.
30 seconds.
No
I
sound.
see a couple other ones. Are nursing homes and ALFs taking extra precautions other than letting visitors in to prevent the spread? Yes, and they are taking precautions that have been ordered by both the federal and state government. And so that involves keeping a log of who visits. So don't be surprised when they ask you. They're doing that for contact tracing. They may also screen you for a temperature before they let you on building. And that, again, is mandated to them. So do not be surprised, and please go along with their processes. It is incredibly important. If you've watched what's happened in that one nursing home out in Washington, there's a huge fatality percentage if this gets into a long-term care facility. And essentially, at this point, long-term care facilities are on lockdown. That's the bottom line, is that nobody's in and out that doesn't absolutely have to be. And they're screening people going in and out, and they're keeping a log of who was there.
Yeah. Let me hop in on that one. So if you're seeing something bad going on out there with nursing home or hospital staff not in PPE or following proper procedures, take and pop an email through your chain of command, and we will give it to the Agency for Healthcare Administration, and make sure that they're being accountable just like we're being accountable. There's a question about the fogger like Hillsborough County used. We looked into that pretty extensively and don't feel that it would probably be a false sense of security. So David Hudak researched it. And basically what we came down to is unless you have wet time on a surface and wipe it physically, you're really just kind of kidding yourself. And by aerosolizing that and then putting it in the back of the truck, you'd have to, he had a chemist friend do the math. You'd have to run it for 5 hours. You'd have to have it open and airing for several hours. And then really because of surfactants and other things in the chemicals, we could have you having asthma attacks or respiratory problems later on. And it really just isn't worth pursuing it. We did also look at the UV light, and the problem is all the areas that don't get touched by light. So really, again, just kind of a false sense of security. Not that we won't keep looking at technology that can help us.
Okay, so there's a great question here about family riders. And that is something that we've talked about, and that is something that we want to discourage right now. I've also asked DOH for any information card that we could hand to a family member or anyone else. But in general, if you're doing full PPE at this point, a family member who does not have appropriate PPE, i.e. a fit-tested N95 mask, should not be in the front of the ambulance. And so that's going to probably cause some difficulty in communicating that, but I'll just ask that you explain as well as you can that in a confined space with somebody who we can't rule this out on, it would be appropriate for them to be in there. And then obviously we can refer them to the health department if they think that they may have been exposed, etc.
Yeah. There's a question about are we working with surrounding counties, and we are. So we're looking at really kind of across the country, everything that we can consume online, and we are talking to the surrounding counties, not a frequent basis, but trying to stay lockstep with them as well. There's a question about are we delaying patient care to take temperatures? I think we're just getting a feels like temperature with a glove, so I don't know that is the situation there, if I read that question correctly.
Yeah, sorry, I was just texting back somebody that says I haven't answered any of Mitchell's questions, but I'm pretty sure
No.
I've answered a bunch of Mitchell's.
That's because that's Ryan. We don't answer Ryan Mitchell's questions. Hi, Ryan.
Question about the Bay Pines entrance.
Bay Pines entrance, they are on full lockdown, and so they have employees going to the south side. They have patients coming to the north side, and there should be a flow for that. I'll make sure that we get that out and what's clear for operations to go to the ER.
Great. Rollins, the deal with the surgical mask is, yes, it could protect your patient from you. However, with our current PPE shortages, I can't recommend that you use one of those masks that we might need to put on a patient who we have high suspicion for, rather than using it for yourself. So if we had as many of them as we wanted, that would be great, but we don't. So I can't recommend that at this point. If we get more of them, then perhaps maybe, but right now we have to really preserve what supply we have. As far as cleaning the cardiac monitors, again, make sure you're referring back to the guidance that was given recently about exactly how to clean the dang monitors. I know that if you don't do it correctly, they cause all sorts of problems to the cables and they don't work right. If you have any questions at all about that, please check with your coordinator, or there's been multiple rounds of information that's gone out about that. Craig, do you want to jump in on that one?
Yeah, I'll hop in on that one. So the main thing is that you've got to get the bleach off of it. That's what really corrodes the leads. And so, if you do like a C. diff type of case in which you have to use bleach, you've got to get that cleaned off and dried, and then cleaned with peroxide. Otherwise, it's going to corrode your cables. As far as just switching the cables, we don't like to do that, because in order for the Philips folks that they're on site at the EMS building repairing, they have to see the entire monitor end to end. Otherwise, they can't replicate what the problem is, and it takes a lot more time in order to do it. So that's why we've really been pushing on, you have the monitor and cables attached, and if you have a problem, we want the whole unit back altogether. Hey, I got a text from one of Lieutenant Mitchell's chiefs saying, great job for not answering his questions. And now that we joked around, we better actually go back, Doc, and answer some of his questions. We got a lot more than I realized that we'd get.
Okay, so I don't know what he's talking about with NASA, so I'm just going to keep going on that one. But there's an interesting one here about corticosteroids and NSAIDs. There's evidence out there that that steroids are making people worse. And so that is why the caveat is in there. If you're treating one of these patients, thank you for texting me the NASA reference there. But if you're treating one of these patients and you suspect that it might be COVID, you might consider holding off on the Solumedrol, and so that would be a good time to check with the online doc about what interventions would be appropriate or not. If you think it's a COVID patient where they meet criteria for us to take those precautions, you might not want to do the NEB either. So again, that would be the time to involve the online doc for guidance on that. If they're a sick person that's not flagged and you walk in, should we back out? Well, again, that's the whole point of sort of the standoff, doorway, look test, dashboard assessment, whatever you're going to call it, where hopefully you just take an extra beat there and eyeball that patient while you're still more than 6 feet away, and ask them a couple of questions about their symptoms and figure out whether or not you think they fall into the categories.
There was a question, Doc, about federal government releasing funds, and so we did receive today what you're seeing of the federal declaration of national emergency, and then the state declaration, and then our local state of local emergency. That's all about flowing funds, and so the state has approved what are called Category B funds, and that allows us to pay for staffing and preparation efforts. So that is something that's underway.
Just chime in on there. At the county executive policy group level, those discussions are happening about how to do all those things. Let's see, what else do we have here? There was this question about pets, and somebody said that maybe dogs or pets can't have it. I've read some contradictory things on that, so if anybody's got a good evidence-based resource on that, I'd be interested to know. Also, somebody needs to take Mitchell's emojis away. Be great, thank you. Any special precautions that you should take if you're on Humira or something like that? Yeah, so those would be the same precautions you should take if you're in any of the high-risk categories, which is be extra vigilant about proper procedures for donning and doffing your PPE. If you use your PPE appropriately, you should be just fine. But if you wipe your eye with your dirty glove or don't take your PPE off in the appropriate way or the appropriate order, then yeah, you're at increased risk. If you have some concern about your particular risk profile, I would encourage you to talk to your private or personal doc, primary care physician, or employee health for individual questions.
Hey, Doc, let's talk about nursing homes. So are we educating them about our EMS PPE? I guess I take that part of the question, and we haven't yet, but that's something that we can do. And do you think that we'll get to a point where we have to have full PPE to make sure that we don't have community spread while we're going into nursing homes for any type of patient?
There's a good chance that we'll get to that kind of a point, depending on what those nursing homes like or look like and how severe it gets. I think you could also see people being quarantined in nursing homes. We just wouldn't be taking them out. So that remains to be seen. Again, I think this reemphasizes just how important it is for all of us as a community to take the responsibility to do social distancing for real. So when you go and you see, downtown St. Pete full of people out bar hopping last night, or the beaches full, or whatever else, people really aren't understanding what it's going to take to slow this down and keep those members of our community safe. So as I said, everything is on the table, and the smartest guy I know to listen to on this says it's going to get worse before it gets better. I want to go back up one to a question on refusal. So if you run on a confirmed COVID patient and you feel like the patient doesn't need to go, and talk to the doc about it, which I think would be a good idea there, and they decide to stay home, are there any extra steps? No, not at this point. If you do that process like you would normally do, you talk to the online doc because you think it's sort of a special circumstance, I think that would be perfectly fine. We would want you to encourage that person to call the health department, and we'd hope to get that information to the health department one way or another about that person if they didn't already know about them. Hopefully, if it's a confirmed patient, the health department already knows about them. As I mentioned before, we are coming up with a paramedic-initiated refusal protocol, but that is not where we're at quite yet. That would be still a little ways out. Here you go. Time frame we are expecting this to last. Well, Billy, that's a darn good question. I think our experience in China says 2 months of real bad stuff. And our experiences in Italy, our experiences in Italy are a little closer to 2 to 3 weeks of the peak really bad period. But again, that probably depends upon just how effective we are with our mitigation strategies. We've got to reduce the rate of person-to-person spread, whether that's in the community or through interactions in the healthcare system. And we've really gotta take those measures seriously.
There's a question about homeless. I'll pick up the first part of that. Is Pinellas County Sheriff is doing advanced cleaning, like and sanitizing, like Pinellas Hope and the jail, and trying to reduce people coming and going from those facilities. As far as getting folks off the street, I don't know that we're to that point yet. But Doc, any comments on homeless related?
Yeah, there is a working group or a subject matter or population lead within the county's emergency management structure related to this. So there are folks actively addressing that population and doing what they could for prevention. There's another one about sending folks out for minor stuff. Yeah, I think you're going to see that more and more. That's not something that we can necessarily control. But as this moves through the community and it becomes really, really clear that anytime we take these patients out of the facility, there's a potential risk, I think that you'll see more and more of the docs that are responsible for those decisions changing the risk-benefit ratio and therefore the decision on whether they need to actually send them out.
There was a question about portable steam. We will look into that. Anything that we can try to look at, we will do.
That's a great point. So I think we're getting close to have covered all of these questions that I've seen come by. So again, if you've thrown one up there and we haven't seen it, please repost it again. And then also, if you wouldn't mind throwing up there any suggestions you have for things that we haven't thought of, that you're thinking about, that you think we ought to be considering looking at, exploring. There's a bit of a delay here, so throw them on up there and we'll see what you guys come up with that we haven't thought about yet. And then again, any questions that you have that need to get reposted up so we can address them, go ahead and throw those up as well. And then while I'm waiting for that to go.
Yeah, we got breaking news that President Trump has said no gathering of more than 10 people in a location. So that'll really slow things down out across the country.
Awesome. The other thing I wanted to ask folks before we end this is while you're also putting up your suggestions for things that we haven't thought of or your reposts of questions we haven't gotten to, it would be helpful to us if you could give us some feedback as to whether this format is helpful to you and we should continue doing these. By these, I mean the question and answer sessions. And I see, what is our working assumption of a single patient in a nursing home being indicative that there is more systemic infection in the facility? Yeah, the answer is if you have a patient in there, the location is going to be under monitoring by DOH, and there's a high probability that other folks in there are going to get infected. Just look at the experience in Washington to see that.
Okay, back to the homeless. We will get back to the homeless working group on getting them off the street. So that aspect of the question we'll pass along.
Mitchell, the washing your uniforms, as far as we know, that's effective, but we'll double check on that. And again, please go ahead and throw any suggestions in here, or email us, or text us with things that we haven't thought of or haven't covered, because this is, as I said, everything's on the table, and just because we haven't said it doesn't mean that we thought of it and thought it was a bad idea. So please throw it up there. As you can see, the country is really taking every measure possible to try and slow this down, and it's for a really good reason. The folks that I'm hearing from other places that have been through the explosion as opposed to the slow burn really would have rather been more aggressive and have been again accused of overreacting. So please keep the thoughts coming and keep letting us know. The autograph expert just jumped on and asked about the decon unit, like HCFR. Yeah, we talked about that. We've looked. and we don't think that that's a good solution for us right now, based on a number of things. The other thing I want to ask the group before we cut out is, are you guys watching this individually or in groups at the station? I think that's
Switch back
an
and
interesting
forth right
thing
now.
for us to know.
So one of the questions was, can we save this? And yeah, we can save it and put it out as a video later.
This will be posted on Target Solutions at completion.
Aha.
Jacob, any thought in the future of limiting out-of-county transports or non-essential? That's a great thing to throw on the list. Again, we are trying to preserve the normal standard of care for as long as we can. I don't know how long that will last. So remains to be seen. Pregnant women having COVID and their outcomes, I don't know, but I would refer you to the CDC website because I'm pretty sure there's guidance there. In fact, I know there's a guidance document on there for OBGYNs and new pediatricians about this. So I know there's a document on there. Okay.
Okay, there's a question about childcare. We'll take that back to Pinellas County Schools and to emergency management as far as childcare for first responders.
All right, so last chance. I think, Craig, unless you or Jasmine have anything else to add.
No, I think that we're pretty well caught up here, and we'll do this again. I think this was really an excellent format. We really appreciate the crowdsourcing of, hearing what you all think and kind of, do we have truth in what we're saying and the guidance that we're putting forward. So this is an evolving situation. We're going to keep working together with you all. Main thing, keeping each other safe and trying to serve the community for as long as we possibly can.
So the last couple of ones I see here is, can we isolate in groups for this? We can't self-isolate at home due to family. Yeah, that's something that certainly you might want to look into. I don't have a good solution on that for you yet. You might want to talk to your agency about what opportunities there are for that. And then Mitchell, if we designate a facility as a hot zone, if and when that happens, we'll try and get some guidance, but I don't know how that's going to look quite yet. And I think with that, we'll go ahead and wrap it up, and we'll plan to do another one of these, like Craig said, before too long. So please stay safe out there. Make sure you're following the guidance. Stand by for updated guidance in the next 24 hours or so by way of a medical control directive, which will obviously do a training video of some sort with, probably like the last one. And if there's any questions, concerns, suggestions, please don't hesitate to reach out.
I'll tell you, keep checking your Target Solutions regularly, and we'll keep you updated, and this video will be posted shortly.
Stay safe. Thank you all.
All the work.